Thank you, John, for the kind introduction, and I would like to start off by thanking the SOLDA leadership and chairs of this conference for the kind invitation, but also on behalf of EASL, where I'm educational counselor at the governing board, I would like to express our thanks and appreciation for the strong collaboration that we have. And I think as scientific societies, we have an important mission, but that mission comes with a lot of challenges, and so building partnerships and doing things together is the way forward and will help us to achieve the missions that we have that is important for our scientific community, but ultimately for the patients that we are taking care of. Now, my task today and the session together with EASL is dedicated to the most recent guideline that EASL issued on hepatocellular carcinoma last year, so it's a quite new guideline. We will treat three topics today, and mine is about screening strategies and some evolutions in there. So these are my disclosures. Now, what is important, and we also highlighted during the previous 2 days, is that we have a kind of holistic approach to liver disease. It's not just alcohol, it's not just viral, it's not just metabolic dysfunction. It's really those different drivers of chronic liver disease that can coexist, and that of course are important drivers for also the risk of hepatocellular carcinoma, which in most indications of course is confined to more advanced fibrosis and cirrhosis, but not in all. And if we want to improve on that, first of all, of course, we have to tackle all those different disease drivers, and that hopefully will reduce the risk of developing the cancer. But we also have, and that's on the bottom there, the screening and surveillance programs that will not, of course, have an impact on the incidence of the cancer, but the aim there is to have an earlier diagnosis and hopefully then to be able to offer more curative management strategies at that time point. So that's really the aim of the screening, and then the surveillance is nothing more than the repeated application of that screening. And it's always something that is a trade-off, because we should also be mindful, of course, not only of all the logistics behind screening, but also the potential harm that screening can induce. So we should not forget that in our equation. Now, there are a few considerations there, because in the end, is there really much new in the guideline? And you should also be mindful that guidelines are usually quite conservative in terms of recommendations are formulated based on the evidence. When the evidence is not very strong, the recommendation will not change, although new evolutions are on their way. What about HCV and SVR and the reports on reduced incidence of hepatocellular carcinoma once the virus has been successfully eradicated? Now, with the CPG, that literature was carefully reviewed, and what is important is to take into account is that basically the risk is driven by how far, at least in Hep C, how far fibrosis and cirrhosis is present at the moment of the start of the treatment. And when a patient is actually already at the stage of cirrhosis, even if a lot of things improve after SVR has been achieved, it's still not very clear if the risk of hepatocellular carcinoma at that stage is significantly reduced. So for the time being in the guideline, we will not change the recommendation that patients that have an indication for screening at a certain time point, even if then afterwards they achieve SVR, surveillance need to be continued. If we have better evidence, probably that can change, but it's also important to take into account that all the trials that have been running, they never were continued afterwards to assess whether truly the incidence of hepatocellular carcinoma goes down with the achievement of SVR. There's a lot of plausibility there and some supportive data, but the evidence, strictly spoken, is not strong enough to recommend that people with advanced fibrosis cirrhosis that get SVR should not be surveilled for hepatocellular carcinoma afterwards. What's the best test? We, of course, know the limitations of ultrasound. Are there alternatives? MRI, yes, but we know, of course, all the limitations of the implementation of that. Abbreviated MRI, there's quite some literature about that, but we should also take into account that much of the evidence there is on patients that had the full MRE, and then there was a study about those abbreviated sequences. That's not the same as just applying that abbreviated MRI in a prospective trial. So a little bit too early to apply that, although in some circumstances it might be useful. Alpha-fetoprotein, also always the same discussion, and also here in the end with the new CPG there is not really a change in the recommendation. We know that as a standalone it's not sensitive and specific enough, but if you add it to the ultrasound you increase the sensitivity. You decrease a little bit the specificity, but you increase the sensitivity. So it's a trade-off between false positive and false negatives, and the guidelines say that you can still continue to use the combination of ultrasound and alpha-fetoprotein or just ultrasound alone. Alternatives for alpha-fetoprotein, yes, we all know that there's DCP, there's lectin-bound alpha-fetoprotein, you have the scores, so they might be useful, but still there the data are too preliminary to already change the recommendations in the guidelines, so we really need to do much more work to validate that kind of approaches. And also again, there's of course the issue of cost and availability and implementation. Screening interval, also a lot of literature about shorter intervals in high-risk patients, longer intervals in low-risk patients. Still the 6 months is withheld as the ideal trade-off between all the pros and cons. Shorter usually you might detect lesions, but they are in a very early stage, and probably detecting them at 6 months instead of at 3 months has little impact on the management results afterwards in terms of prognosis of the patients, whereas prolonging longer than 6 months, you might have some cases that are in a more advanced stage when they are discovered with less options for curation. So the ideal screening period until now is still 6 months. So you see that even with the new guideline, it's quite a conservative approach that not dramatically changes what has been proposed so far as the guideline. However, is there room for refinement? Well, probably there is. You know, of course, that in general, and it's not applicable to all diseases, but in general, of course, patients with cirrhosis should be screened and surveilled. But what about those with advanced fibrosis? And as already discussed also yesterday, we are evolving a little bit towards the concept of compensated advanced chronic liver disease. Again, this was put forward on a Bavino conference, so the little town in the north of Italy where every 5 years we come together with a bunch of fanatics in portal hypertension to discuss how we can improve the management. And one of the meetings proposed then this concept of advanced chronic liver disease that is reflecting a little bit the spectrum between advanced fibrosis and cirrhosis, because it's not always that clear, and there's not such a line you pass by to get from no cirrhosis to cirrhosis. It's a continuum, and it's also a pragmatic approach because it's not based on biopsy, but it's based on liver stiffness, which of course comes with some limitations, but it's more practically applicable. And you have that famous rule of 5 telling you that if you are below 10 kilopascals with liver stiffness measured by transient elastography, you're very unlikely to have advanced chronic liver disease. If you're above 15, it's quite likely, and if you're above 25, then it's also likely that you have clinically significant portal hypertension. Now, we did a study where we started off with not patients with cirrhosis, but patients with that definition of advanced chronic liver disease. It was based, this study, on another technique to measure liver stiffness, and I would like again to emphasize that liver stiffness does not equal transient elastography or fibroscan. You have other modalities that we need to learn to work with. This was with 2D shear wave elastography. The criteria are a little bit different, and we studied over 3,000 patients, and what we found was, and just for the patient distribution, this was a mixed etiology with quite a substantial proportion of patients also with viral hepatitis, some of them controlled, others were not controlled. And the parameters that in the end had an impact on risk refinement were then included also in what finally was called the PLEASE score, so the platelets, of course, with an inverse relationship. The elastography is clearly an important determinant of the risk because it reflects liver health, not just fibrosis liver health, but also age, sex, and then the etiology. Steatotic liver disease was clearly driving the risk. And in terms of viral hepatitis, it also had an impact, but it was mostly the uncontrolled viral hepatitis, whether it was B or C, that increased substantially and significantly the risk, and not the well-controlled viral hepatitis. You can then calculate a score with high risk and low risk, and you can see that there is a clear separation in terms of your risk of hepatocellular carcinoma according to that risk score. And what I will not show you is also the cost calculation that we did with then a refined screening. So again, 3 months for those at high risk, 1 year for those at low risk, and it's also clearly cost effective. So we are step by step accumulating the evidence that we probably can find ways to refine our screening strategies instead of applying the same to all. This has also been more or less validated in another very large cohort you see here that I cannot fortunately point it out, but if you look at the upper panels, you see the numbers of patients in the different cohorts, and here in this risk assessment score, you see that there are several parameters that were included, but some are the same as in the PLEASE score. There's liver stiffness there are platelets there is age, and there is also the gender of the patient. So those factors come up in several studies as markers of increased risk, and you see on the right-hand side that liver stiffness there is a very important determinant in the ultimate risk. And also here you see that with this score, the SMART HCC score, it was called, you can risk stratify the patients and you can tailor your screening strategy based upon that. Now, coming back to the guidelines, because I mentioned that this session is around the HCC guideline, but there's also a brand new HBV guideline. What do we find there? But first of all, the recommendation is, and it's a little bit cryptical, of course, patient at risk of HCC should, of course, be screened and in surveillance. That's quite an open door. But what is in that guideline defined that patient at risk? And you see it summarized here in this table. Of course, it's patient with cirrhosis. That's obvious that surveillance there is recommended. Then you have those without cirrhosis, but at intermediate or high risk. They should also go into surveillance. And those that are without cirrhosis and at low risk, their surveillance is not recommended. That's how it's phrased now in this most recent guideline that only came out very recently. Now, what is it then? High risk, low risk, intermediate risk? Well, the guideline makes reference to several risk scoring systems, so it's a more refined way of assessing the risk, and you see that step by step that more refined risk assessment and tailoring your screening strategy based on that risk assessment is finding its way to the guidelines. And what is most promoted in the guideline is the page B and the modified page B, which is based on, as you can see, sex platelets, and then in the modified one on albumin, and you can calculate a score, and if it's 10 or above, you are at an intermediate or high risk, and so you should go into a surveillance program. But you see, as I said, there are several of those risk scoring systems, and you see here the list that was retained in the CPG on HBV. And so also in the recommendations and the statements, you see that individual risk assessment, if you take the upper sentence, can be enhanced by applying risk scores. So you see it's step by step being incorporated in our guidelines. And it clearly says that, of course, if they are effectively treated or not, if they are at risk, they should continue to be surveilled. And also in the guideline, we emphasize again that the evidence is very important. And what is explicitly mentioned also in the text of the guideline is that for patients of African descent, we lack the data. And so there, the guideline clearly says that a more conservative screening strategy should still be considered until we have the data, and then based on the data, we can change the recommendation. So I think that it's quite essential. So to come to a conclusion, I think we all know what the aim of screening and surveillance is. The global strategy has not fundamentally changed, but we are step by step getting towards systems that have a more refined risk-based strategy where liver stiffness, platelets, the etiology, all come into play and allow you to have a better stratified risk assessment, and you can then tailor your screening strategy based on that risk assessment. But for most of those approaches, we still need to gather a lot more data so that we can really have the evidence to change our formal recommendations in the guidelines. And also regarding the emerging markers and newer imaging techniques, the message is we have to do the research, we have to come up with the data, and then we can, as evidence-based as possible, change our recommendations. And with this, I thank you for your attention, and I thank also again the organizers for the collaboration. And I think, John, we can move to the second presentation because we will keep the questions for after the three presentations when we have hopefully about 15 minutes for discussion. Thank you.